Hello and welcome to CD Oasis. I am Shiraz Gesayer and I am joined with Dr. Paul Belziki. So, hi, Dr. Belziki. How are you these days?
Well, given all of the extenuating circumstances, I've got a lot of time to do these presentations.
Thank you for taking the time and presenting this case with us. Can you, in a few words, tell us what we're going to be watching?
Yeah, the case is, and I find this is the best way to get points across, is just to handle one case, just to see thought development. And this is with regards to immediate placement of a bridge on the day of extraction of teeth. And this is very beneficial. It's a great modality for folks that don't want to go the route of implants, for folks that can't be without teeth, that can't go through the whole rigmarole of an implant case. So it's just how to handle it, and I just run through a case from start to finish.
Perfect. So let's share your screen and start the presentation.
Okay. This presentation concerns itself with the immediate bridge. For those of you that have time, because of the coronavirus, and this is the first time you've joined in on these presentations, let me tell you I'm a general practitioner. I provide periodontal surgery, endodontics, and restorative dentistry. And I endeavor to integrate these protocols to deliver long-lasting restorations in terms of decades, because that's what I would want if I'm sitting in the chair receiving care. Like, fix it once, fix it right. And after 40 years, I've restored just about everything there is to restore in dentistry. And hence, I'm well-versed in what does work and what does not work. And I'm inclined to do it old school. By that, I mean, I rely on evidence-based protocols that have proven successful, not only in my hands, but in the hands of well-recognized clinicians and educators who wrote the rules of the game long before I arrived on the scene. I'm not inclined to reinvent the wheel. There is no Belziki technique. Perhaps what's unique to me is the manner in which I sequence the phases of dentistry and provide them. And note that success is a planned event. You just don't bump into it haphazard. You have to do every little step right. So what is an immediate bridge? Well, it's the fabrication and insertion of a fixed provisional bridge immediately on extraction of teeth. After some months of socket healing, or if you have to do periodontal surgery, the final bridge is delivered. And there are various reasons for extraction. Ones that I can think of are disease, trauma, and reasons for aesthetics. And this case concerns itself with disease. What needs to be in place? What is the one thing you have to have in order for this to happen? Well, you need good, solid abutment teeth on either side of the extraction site. So the ultimate treatment goal is to provide predictable treatment that will survive the test of time. And after 40 years of clinical experience, I can tell you that the materials I rely on are amalgam, gold alloys, cast gold alloys, or silver palladium alloys, either by themselves or porcelain fused to metal. The past dozen years or so, I've used zirconia, and I will use zirconia bridges, but they have to be small and in the anterior. And composite resin is way down on the list, and you have to beg me for me to put it in. Now, this is the first case I had done before cosmetic dentistry was a buzzword. This is an older gentleman. In '83, I was I was exactly 30. He may have been around 50. And he was brought up in an era of no fluoride, so there was a lot of acrylic on gold that had been in his mouth for many, many years. And for the longest time, he lived with this tooth that was just stuck out in space. Successful businessman, aesthetics just wasn't so key early on. And he said, Paul, this is really starting to bother me. What can we do? So I said, okay, we'll pull out the tooth, make you a provisional bridge, and then make you a final bridge sometime later. So these photographs are off of Ektachrome slides. This is before computer, before digital. So I did the best I could to copy these from Ektachrome slides. I had extracted the tooth. This is the day of insertion. And there's the bridge. And at that time, where everybody was fond of metal margins, we would just tuck them under the skin. Nobody took us to task on it. It was a different time. Aesthetic demands are somewhat different. And that's the day it was inserted. And my lab technician, who I used for 25 years, went to a great effort in order to match the discoloration or the yellowness of the adjacent central. And that has been in his mouth for some 30 years. And here you can see I put that in 1983. He had moved abroad. I had, over the course of time when he lived in Toronto, I had redone much of the bridge work. So much of this bridge work is 30 years old. And he phoned up one day and he says, I've got family in Toronto. I'm coming into the city. Something's bothering me with this front tooth. Nobody knows what it is. Can you have a look at me? And he came in and I did. So it was determined that there was an extensive defect in this area. Don't know how it happened, but that tooth had to be removed. And the treatment plan was to prepare the lateral and remove the bridge, which I had put in some 30 years ago. Now, when you're young and you're doing this for the first time, all those memories are emotional. And I remember doing this. I remember the conversations I had with them. And it was with some emotion, I started to cut this bridge off that had been in service for 30 years. And that's the instant I removed it. And that's what it looked like some 30 years ago. So well-constructed porcelain fused to metal bridge work done properly will withstand the test of time. If I didn't have to cut this off because I needed, because of the extraction of this central, he would have lived with this his entire life, which is the goal of dentistry. And here is the interior of the bridge. I'm always fond of saying, when I cut bridges off that I've cemented in with poly-F cement, polycarboxylate cement, the cement invariably looks like the day I put it in. And to get this off, you have to pretty well grind this off. It fits very, very intimately, good mechanical retention and all the little grooves. Obviously, this isn't bonded, but the cement withstands the test of time. It doesn't go anywhere. It doesn't dissolve. It doesn't break down. And I've tried newer generation cements to regret it. So this cement has withstood the test of time, and it's the cement I'm still using to this day. So again, 1983, some 30 years later. Teeth look perfect, like the day I put it in. I haven't held up that nicely by comparison. So porcelain fused to metal, that gives me justification for continuing to do what I've always done. And I will present it in this case. So this patient has been coming to me since 1980. She came at the practice that I bought. She's been with me for all of these years. Some of these teeth were gone before I bought the practice. I had done some bridge work here, a couple of crowns, but by and large, she's had no treatment done. She's about 90 years old, Italian. She physically and mentally, she's very sound for her age. Wonderful, sweet Nona, grandmother, great-grandmother, but very, very stubborn. So she comes in, she used to come in regularly, but lately, every 3, 4, 5 years, she seems to show up. Her son brings her in when it comes sometimes. And he phoned up, said, Paul, we have a problem. My mother can't eat. Her front teeth are bugging her. They're loose. So she comes in, I do my examination. And as is always her case, there's a sweet side, then there's a stubborn side. And she says, Paul, you do whatever you want. No implanta, no dentura, and no costa too much. So her son's listening off to the side. I can see him, and we have an arrangement. Do what you got to do. Charge her $300 or $400 so she feels that she pays something, but he'll take care of the rest. And I told him that these teeth have to go. There's the radiograph. So she had lost, as I said, these teeth are being lost due to periodontal disease. There's just no saving these. I still take stone models, organic, alginate impressions, if you will. I have not gone digital because I need to have things done quickly at my office. I can't send something off, get it printed, I don't know when, and get it back. The patient is in pain. The patient wants treatment now. The teeth are loose. So I still work in the realm of alginate impressions. So this is a stone model. And then taking blue blockout material, I'm going to make my provisional. I'm going to use this to form a vacuum form shell to make my provisionals. So here I just use some blue blockout material from the lingual, from the facial. This little bit here is where the alginate got locked in and ripped when I went to pull it out. But that's of no consequence. I don't have to be too artistic here. Just flood it with some resin material, draw a sheet of plastic over it. These acetate sheets, they come in two varieties. One will stick to acrylic and one won't. You want the one that doesn't stick to acrylic. And then a line is scored at the gum line from the facial and from the lingual. And you now have a shell on which to make a stent, on which to make your provisionals. In this case, because I don't have a lot of teeth to work with, what I had done initially was prepare the 44, the 34, and the 35, and I left the two cuspid teeth unprepared. Judicious tooth preparation is very important. And when you say tooth prep, crayon prep, I've learned from giving lectures and talking to people, everybody has a different concept of what a proper crown preparation is. And as far as I'm concerned, you need gently converging axial walls of a sufficient length in order to provide good resistance and retention form. Sorry if this one's a little bit out of focus. So I prepared the bicuspid and the two bicuspids on the other side, left the two cuspid teeth, and they will serve to index the acetate sheet. So I can pop it on and it locates this sheet properly so that I can flood this with acrylic and pop it back onto the teeth. I know there are there's techniques where you take an impression in silicone of some kind, VPS impression material, and then you fill that and pop that back on. That's never worked for me because I can't see if I'm seating it properly on the teeth. With these acetate sheets, I can see it go to place. It also tells me how my reduction is, if I need a little bit more. So this is a good guide for tooth preparation as well as making the temporaries. Methyl methacrylate powder liquid is the material I've always used and will use till the day I retire. I have not used the composite resins. I need a material that is durable, but more importantly, can add to itself a multiple number of times because there's always ongoing revisions with these long cases. And powder liquid methyl methacrylate gives that to me. So I've just poured that into this little acetate stent, pop it onto the teeth. So it's old school crown and bridge braid, baby. And to paraphrase Robert Duvall in the scene from Apocalypse Now, I love the smell of methyl methacrylate in the early morning. This has never bothered me. And if a patient says, oh, it smells bad or it tastes bad, well, hey, if it smells bad and tastes bad, it probably works pretty good. And that's the whole Buckley's claim too. So during this phase, while it's on the teeth, very important to jiggle wiggle it while it's on the teeth. This material remains doughy and goes progressively, slowly to getting harder and hotter, and you don't want this to set on the teeth. So I can feel it. I can feel it getting a little bit stiffer. I can feel it getting hotter, and then remove it. And there's the teeth. I've thrown, as you can see here, I've thrown some sutures in here right now. In the old days, we had a material called Burlue dry foil. If anybody has some that they're not using, please send it to me. It's not made anymore, but it was a wonderful material that you could lay over extraction sites so your resin materials didn't go into the socket. Today, I use lead foil from the periapicals. Then I will take a fissure burr in an electric handpiece, slow handpiece, and just hollow grind the teeth or the retainers that have been prepared. Then go ahead and prepare this cuspid. Again, crown preparations. You don't want to beat these teeth up. You don't want to injure the nerves of these teeth. You have to go slow and easy and follow the contours of the tissue up and down very cleanly. You want to avoid injuring soft tissue, and you want gently converging axial walls of a sufficient length to ensure good resistance and retention form for the course of a lifetime. So again, this is what has to be in place. Try to get them as parallel as you can, gently converging so that you're not blocked out or there are no undercuts. This one cuspid, I had her bite down and I could see that indeed there was good clearance. Prep that tooth and making sure that all the teeth are as parallel as I can get them. Once I've prepared all the teeth, I put the stent back on with the acrylic, making sure that it goes to place. As I said, I've hollow ground these retainers and then just fill it with very soupy methyl methacrylate again, then the resin acrylic, pop it back onto the teeth. And then through that little phase of making sure that I don't walk away, that you don't take a phone call, you don't get involved in the conversation quickly with a hygiene patient where you thought you could run in and out, because if this hardens on the teeth, it's all hell to try to remove. So you stay with the patient, takes 4 or 5 minutes. And what I've done here is essentially one impresses the margin of their prepared teeth. And now I do my 3D digital printing. I use my 10 digits with an electric handpiece, straight handpiece, a medium sandpaper disc, and just go around and start knocking off the excess. It's a little bit slow because I'm trying to center this in the viewfinder and carve the teeth at the same time, but I can move a little bit more quickly than this, but you just take care to knock off all the excess and try to define the margins. And using a sandpaper disc, flipping it back and forth, using it forwards and backwards, I can get into all the little nooks and crannies and embrasure spaces, and it's all done with a sandpaper disc. There's no need to rush. Now doing this, I've done thousands of these. I've carved every provisional that has ever gone into one of my patients' mouths. So this is the shape that I came up with, and I knew I wasn't too thrilled with it. But I ended up taking, again, another mix of methyl methacrylate, just layering it over everything and on the occlusal surface. And I just said to the patient, while it's in the doughy stage, bite down, and I can see where the occlusion is, and then I can start refining it again, and kind of carving by hand the shape that I need. as I said, or I'd like to say, this is an artistic endeavor. Dentistry is still a craft of the hand. I don't like to rely on other people, and I don't like to rely on designs that are generated by somebody else. When I do this, I'm trying to give the lab, once it's all done, an image, a contour, a shape of what I've determined is correct. And here after playing a little bit, adding and subtracting, because you can do that with methyl methacrylate resin, and there's the completed provisional from front to back, carved all by a sandpaper disc in an electric handpiece, as I've shown you, and then it's just polished with a soft flex disc and some Vaseline. And it's inserted, and the patient walks out with this. So the teeth are removed, the immediate is put in, and the wonderful thing with this is that this 90-year-old woman is never without teeth. She's not going to complain to her son, what a dentista do to me. It's just she walks in with a problem, she walks out better than when she came in, and she has the security that she can go home, tend to her aging husband, knowing that she doesn't have to worry about dentures. She's better off than when she came in. So the person is never without teeth, which is important, particularly in anterior cases with people that are in business and don't want to go through a long, protracted implant case. So the resin material that I use, methyl methacrylate, you have to make your provisional as accurately fitting as possible. It has to be durable and easily repairable if something cracks or breaks. It must allow for easy refinement or revisions on an ongoing basis. The whole intent is to restore immediately form and function and maintain this over several months during the healing phase. It must be contoured to be harmonious with host tissue and, of course, the occlusion. And this whole endeavor will serve as an invaluable guide for the lab phase. And nothing, in my opinion, comes close to conventional methyl methacrylate resin. So 3 months later, and there we have it. And the tissue's tightened up. I could have added some acrylic here if she would have come in and say, it's bothering me, I'm getting food stuck under here. If this was a younger woman and it was in the anterior maxillary arch, nobody would want to tolerate that. So I can easily add more resin on an ongoing basis. Teeth are healthy. So at this stage, at this appointment, the provisionals are removed. My plan is to re-prepare the teeth and take an impression. And you can see how nicely the soft tissue has responded when the provisionals are of a correct contour. I've taken the temporary here. Again, I've hollow ground it after I've prepared the teeth because I now have to refine this to close up the margins, the newly trimmed margins. So it's taking the old bridge, putting a new resin, popping it on, and then refining it. Making sure that the embrasure spaces are all there so she can get in, the patient can get in with little interproximal brushes and maintain good, healthy tissue. Here's another little trick with methyl methacrylate. I want to take a bite at the level of the of my provisionals. Let me just go back here. So what I did was take the sandpaper disc and just cut through there. Pop that crown, that single crown on the tooth, and then take a bite. So this gives me the stop of the vertical at the same height where the provisionals are. I don't want to change that. I don't want to alter that. So with that one crown in place, I've taken the bite registration material, VPS impression material, and then once that's set, at the site 35 was where I had the temp, I just put some new material there, pop it back on, have her bite down, and now I've secured a relatively good, decent bite at the vertical that the temporaries are at. I flow a little bit of new material in between these two teeth, and it lutes it all together, and I'm back to square one. So as I said, methyl methacrylate resin facilitates the reattachment of the crown 35. And it's a wonderful material because it chemically adds to itself. I was told not to put things in capitals because it means you're yelling. I'm not yelling, I'm just trying to be emphatic that this is a wonderful material. Impressions. If you can't see it, neither can anybody else. It just ain't there. So one needs to be honest with themselves that if you miss anything, you have to go back and do it again. I'm still using VPS impression material in a custom tray. We make 2 or 3 of them, depending on how big the case is, because I may have one go around and I may get an air bubble on one where the rest of them are perfect. I don't want to strip it all out just for that one air bubble, because then I may capture that and get a void somewhere else. So every impression I send to the lab is picture perfect. That doesn't mean every impression I take is, but the one that gets sent, usually all the information is there. And is there 360. You can't fool anybody with this. And what I do customarily is take some new impression material on the end of a probe and just lay it in up against the margins and in between the teeth. That way, when the stone gets poured, it's away from the stone model so that a tech doesn't come a little bit too close and nick a margin. So in this way, I ensure a bit of security that I've kept the stone away, that the margins just pop out in the stone. And it's the same thing on this side as well. Again, you have to notice 360. Did every detail get captured accurately? I don't use, or I haven't gone to digital. I'm still very comfortable with stone and impression material. I get every case back bare metal because I need to assess the efficacy of the design that the tech had in mind, and I want to check the accuracy of fit, of every component. So these are all sectioned, and I take my little fingers with my little pressure transducers that are in there, and I jiggle it down on the tooth, and I want to feel that thing go to place, bang, without a rock, without a wiggle. Because it's in separate units, this is easy to assess. Sometimes a little bit of maybe some stone or the casting or something was off. Yes, it fits perfectly on a model. Yes, it may fit perfectly on a computer screen, but that's not the patient's own tooth. And I need to know how these things fit on each and every individual tooth. So I go through this phase. And it's invaluable in paying attention to detail. So here you can see I've asked for metal on the distal marginal ridges, because if a patient's going to break porcelain off of a porcelain fused to metal bridge, it's usually in these areas on the distal marginal ridges. And there's an occlusal stop that's built in, so I can ask the patient later, once I've jigged this all up, to bite down, and I've got good occlusal stops. So there's security in transferring the information from the articulator to the patient back and forth. The provisional now has been in place for several months. The tissue's perfect. The patient's been test driving this. I can eat, I can bite, I can chew, I can speak, I can do everything that I need to do. So my job now, my goal is to guide the lab to replicate this design. not something that they have in mind that they think might work, but I know that this has proven itself successful, so I have to replicate this. You can see how nicely little triangles here. I know the scourge of dark triangles. I happen to love dark triangles because I know I can get an instrument in between here and the patient can clean in between here as well. If this is a younger female, upper arch, okay, I understand that's a different story. We have to compromise. But here on an older woman, bit of arthritis, manual dexterity isn't what it used to be. The easier I can make it for her to clean, the longer this bridge will last. So again, the provisional is removed. The tissue just looks absolutely peachy keen. There's no bleeding, there's no weeping, the margins are accessible. I don't have to fight at this stage. And again, accurately fitting provisionals promote a good, healthy periodontal status. So now I try these things in. Does it fit? Does it rock? Where is the metal too proud? I don't like this area. They've closed it up. Once porcelain gets placed in here, it may obliterate that embrasure space that I need for cleaning. So in the bare metal phase, in separate segments, I can come along with discs and just start grinding and reshaping it to what I think is correct. I don't want ridge lapped here, so a little bit of metal has been taken away to bring that lingually so that I have more of a bullet shape pontic. And you can see that I've opened up the embrasure space right there. And these things are important to me because, as I said, I don't want it coming back, the tissue's bleeding, all the work I've done into making it healthy. One little thing can trip it up and all of a sudden I've got a maintenance problem. So I'm ensuring that I've got a design that mimics what I want. And just go ahead and do that. Here I could see that the solder index would not, would obliterate that embrasure space. So then it's easy to come in here and just remove some metal in order to widen out this embrasure space. And these are all the little things I do. That's where I want the pontics. So just start taking away some metal. And just over the course of a long career, I know what will work. And now I go ahead and start intraoral solder indexing. I've got the occlusal stops here, and then I start to add this section to here, and then I'll attach these three segments together, and that's all hardened. And then once that's done, making sure the metal doesn't bind and putting some resin in that area as well. I use the tooth-colored material. You can use the pattern resin, Duralay resin, the red resin as well. But this, I've got so much of this, it works every bit as well. And there's the occlusal stop on the corner, and that aids in taking another bite. Now I have to make a solder jig, because invariably this indexed framework invariably will not go down on the master model as passively as it should, because how it fits on the teeth is a little bit different than how it fits on the model. And I've got to give them a jig, a verification jig, to how it's oriented on the teeth. So this is how I go about doing it. I've tried that framework on and off the teeth multiple times, and I've assured myself it's not rocking at all. A second pour was done and provided by the lab, and these are pin dies. And at this point, each die is inserted in the respective retainer. This is some sticky wax with a Bunsen burner, and attaching each die into the retainer, joining it all together so that they don't come loose and they don't pop out. Sometimes if it's a small case, I'll just pop the temporaries back into the mouth and dismiss the patient. But in large cases such as this, I'll have the patient stay in the office and do this, because once it's fabricated, I still want to try it on and off the jig and on and off the patient's mouth to make off the teeth to make sure that nothing has changed and nothing's altered. I'll flip it around and just add a little bit more onto the lingual aspect. I don't want any of these dies coming loose. Then take the entire complex and just park it in some stone. After 20, 30 minutes, the stone is hard enough, it can be removed. And now I have a verification jig, a solder jig, where I've related the dies, how they are best situated in the mouth. It slides on and off passively. I can go back to the mouth, the patient is still here, and make sure that that's the case. There's the master model, and I'll tell you that it does not go down 100% cleanly on the master model. After they're processing, soldering, porcelain, etc., it must fit the solder jig. If it fits this, it will fit the mouth. It'll jump onto the teeth. And indeed, it did. So here you can see the finished product. We've left that area in bare metal. I assume at a later date, if she did want a partial, this would be absolutely perfect. But I know she doesn't want one. But that provides security so she won't crack the distal of the marginal ridges there. So I love porcelain fused to metal, and I think you should too. It's durable, it's predictable. If you run through some of these steps, or all of these steps hopefully, you get a perfect fitting bridge, and there's security in that. This is the day of insertion. Never fighting blood, never fighting weeping tissue, because the provisionals have maintained good solid health. So I've replicated that design, and there's the case cemented in. And hopefully she goes the rest of her life with this bridge. So what I love about immediate bridge work, aside from the patient never being without teeth, is before I started, before I picked up a drill, before I gave her local, before I even talked to her about it, I knew with certainty I could get this end result. And as a dentist, my job is the creation of functional artwork to withstand the harsh environment of the oral cavity. So as far as I'm concerned, dentistry, dear friends, is still a craft of the hand. It's the fusion of science and healing art. And that knowledge of what's right and what's accurate and the skills required must be within the self. It can't be in a computer somewhere. You have to know what's correct so you can at least dictate to a tech or a computer screen what is right, but you have to have that knowledge within you. And initially, early in a career, you have to struggle to make it so. Yes, I can knock off a big bridge now, but when I first started, it took a while. And the wonderful thing about methyl methacrylate is you're carving it, you take off a little bit too much, no problem. You can add it back in 5 minutes. Back and forth till you get it just so. And that, my friends, is doing it old school. It's going to be a rough while now with the whole virus thing. I hope I've provided some interlude in all of that. And I hope when I return with another video, everybody will be back to normal and we'll all be engaged in practice. And I've practiced enthusiastically for 40 years, and I hope there's still a good few years left in me. Thank you very much, and stay safe. Bye-bye.